final chapter in the ultrasound guided regional anaesthesia. Today we're going to look at lower limb, and specifically the femoral nerve, the fascia iliaca plane block, the popliteal sciatic and the saphenous nerve blocks. So first off, the femoral nerve. Now, the femoral nerve is very easy to find with nerve stimulator and can be frustratingly difficult to find with an ultrasound probe and needle. So just a quick reminder, obviously it comes off the lumbar plexus, with L23 or L234 components. It sits on the iliacus muscle and the psoas muscle, so which together kind of inferiorly form the iliopsoas muscle. And runs sort of underneath the inguinal ligament before proceeding to the thigh. Now, traditionally, the sort of 3-in-1 block that people wanted to block were the lateral cutaneous nerve of the thigh, the obturator nerve, and the femoral nerve. And you can see here that this hook is in the fascia of external oblique. This hook here, you can see the internal oblique and then the transversus fascia. Now, the transversus fascia is in fact continuous with the fascia iliaca, so that explains why, if you go inadvertently one layer deep, you can very well 10% of the time you're likely to get a femoral nerve block, just because if you get local anaesthetic below the transversalis fascia, it will also be below the iliacus fascia, so you'll get an inadvertent fascia iliaca compartment block, or a femoral nerve block. But just to illustrate the anatomy of where these nerves run sort of through the pelvis as they go down the leg. So crucially, as we said before, this is the right femoral area viewed from below, and you see that the arrangement of femoral nerve, femoral artery, femoral vein from lateral to medial. You see the fascia lata and then the fascia iliaca. Now, crucially, the femoral nerve sits below the fascia iliaca and sits on iliopsoas muscle in the femoral triangle. So in this scan, clearly here we can see the femoral nerve, and laterally we've got the iliacus muscle. Now, traditionally, people have said if you just aim for the triangle lateral to the femoral artery, you'll get the femoral nerve. But I think we need to be a little bit more precise than that, because when we play this video, I'll point out where the femoral nerve actually sits, and it's a little bit more lateral than you might expect if you were just kind of aiming for that triangle. So what perhaps a better aim would be is to aim for the tip of this triangle, ensuring that you get below fascia iliaca. And in this video clip, just watch this area here, which will be the femoral nerve. And in this clip, the patient is just gently flexing the hip, so activating iliopsoas muscle, and you can see that sort of delineates it from the kind of the fascial layers above. So there's femoral nerve there. Which is a little bit more lateral than you might expect if you just went for the tip of the triangle lateral to the femoral artery. So the probe would be transverse, and you could have an in-plane approach from lateral to medial. It's only about 1.5 to 2 centimeters deep, so it's not a deep block, and it ought to be straightforward. But certainly, it's frustratingly difficult compared to how easy it is to do with the block is to do with a nerve stimulator. So moving on to fascia iliaca compartment block. Again, just a brief reminder that psoas muscle and iliacus join together to form iliopsoas. It's a powerful flexor of the hip, and it inserts anteromedially in the thigh, and crucially it exits the pelvis over the inferior pelvic brim.
so obviously under the inguinal ligament, but it kind of exits kind of anterior to the pelvis. So when we're looking at a scan, or rather the anatomy, again here we've got iliacus muscle, and here's psoas. Now there is a fascial layer which sits on iliopsoas and covers lateral cutaneous nerve of the thigh, the femoral nerve, and the obturator nerve. So conveniently, if we can get local anaesthetic underneath that fascial layer, and if we can get a large volume of local anaesthetic underneath that fascial layer, we should be able to get all those three nerves blocked with one injection. Now, the position for the fascia iliaca block, this is from neuraxiom.com. So if you put the probe in this sort of orientation, just medial to the anterior superior iliac spine, and then move the probe 2 to 4 centimeters medially, you should be in about the right position. And sometimes if you point the kind of cephalad end of the probe slightly towards the umbilicus, you'll just clear up your view of the compartment, of the fascial layer. Now, what I was saying earlier about finding the landmarks, the key things you want to know are, there's the inferior pelvic brim, so there's the ilium. On the left hand side of the screen is cephalad. So the probe is positioned as we saw in the previous diagram. The blue dot is the head end. So here we've got the ilium. Now we know that the muscle that sits directly on the ilium is the iliacus muscle, or iliopsoas muscle. So we want to find the ilium, number one, and then we want to find the muscle that sits on top of that, number two. Now in this area, carefully, there will, in a cephalad direction, there will also be muscle. Now these are the fibres of external oblique. Now it looks slightly different from the iliopsoas because the fibres are running in a different direction. And if you were to go slide the probe further towards the head, you may also see bowel in this area here, bowel underneath the fibres of external oblique, but sitting on top of the fibres of iliopsoas, as iliopsoas dives posteriorly around the back of the pelvis. So again, in this clip, I've just got the patient to gently flex and relax the hip joint. And you can see about here, there's an echo-dense layer on the iliacus muscle, and that's the fascia iliaca. So just at this corner here, you can begin to see the bottom edge of external oblique, and as we kind of move further towards the head, you'll begin to see bowel here. So where we want to get local anaesthetic is through the iliacus fascia, but superficial to the iliacus muscle. So in this layer here. Now this is a video where taken from the internet, where the group have turned the probe at 90 degrees to the way that I've showed you. So what they can see is sartorius muscle. So there's sartorius muscle. There is iliacus muscle, and just disappeared there was the ilium. So what they do here is pop through the iliopsoas fascia and then inject some local anaesthetic. You can see it. Once they inject, you can see it just splitting the sartorius from iliacus, and then just they've moved the probe much more medially to see the femoral nerve. So they're now filling that space with local anaesthetic, and it should migrate sort of sufficiently medially to block the femoral nerve and all three components of the 3-in-1 block: the obturator nerve, the femoral nerve, and the lateral cutaneous nerve of the thigh. And crucially, you can see this is a 2E needle, so it's very important that this is a blunt needle. So in our hospital, either a plexifix or a paediatric or even an adult 2E needle, just so you can feel the pops as you go through the fascial layers, in addition to seeing the pictures on ultrasound. And again, set to some fantastic music. This is a Spanish group who are doing a landmark iliacus fascia iliaca block. So all the subtitles are in Spanish, you can work them out. So they're doing this block on this Spanish lady, drawing the inguinal ligament and dividing it into 3. And then sort of a centimetre cord. They certainly have a fairly generous centimetre, finding the femoral artery. So what they're very careful to do here is just make sure that they get through the skin before they start sort of advancing and counting the clicks. Now, the clicks they're going to feel are the fascia lata and then the fascia iliaca. So you can see 2 kind of fairly distinct pops there. And as this is a field block, the volume of local anaesthetic is far more important than the concentration. So what we want to do is instill a sort of a large volume, so 30 to 40 mils of a dilute solution of local anaesthetic. Now what they're seeing here is just the local anaesthetic sort of refluxing out. That illustrates it's in a fascial compartment rather than in the muscle body. So that's a positive sign that we're in the right spot. And then they carry on to thread a catheter after they've hydrodissected with local anaesthetic. But again, just a reminder of anatomy. I mean, essentially, if you get the local to travel far enough posteriorly, it's essentially just an anterior approach to the lumbar plexus. Now, I certainly wouldn't advocate advancing the needle that far. Certainly, when you do sort of get in the right plane and you kind of dissect out the plane, it's a good technique. It's perfectly valid to advance into the space you've created to make sure you get local anaesthetic more proximally. But the point of the big volume of this block is that it should spread proximally without you having to advance the needle too far. Right, so the popliteal sciatic. You can block the sciatic higher in the leg using ultrasound. It's a little bit more difficult just because it's deeper. But so today we'll just deal with the popliteal block and the saphenous block. So that basically will give you a complete block below the knee. So here we've got a posterior view of a left knee, and the 2 important nerves are the tibial nerve here, which is medial, and the common peroneal. Now, this division of the sciatic nerve is very variable. It can happen as high up as the sort of subgluteal area, or it can happen as low down as the posterior crease of the knee. So the big advantage of using ultrasound to block this nerve is that you can see where the 2 nerves separate, come a little bit proximal to that, and then you can confidently
get both components of the nerve with one injection. So this is one block. If you just put the probe behind the knee, you should be able to see, just in the posterior crease of the knee, you should be able to see the two nerves. So tibial, we'll watch this video again, tibial and common peroneal, you should see them both joined together. So what we'll do is just play that again. So we'll pause it there. So here is the tibial nerve. So that the blue dot in this case is medial. And here is the common peroneal nerve. Now we'll just watch them kind of come together as we slide the probe up popliteal fossa. Now here, the two nerves are joined together in one fascial sheath. Now the next manoeuvre is just to get the patient to plantarflex and dorsiflex their foot. Now what that does is, because the two nerves are still separate but enclosed in the same sheath, and one goes anterior to the axis of the ankle and the other goes posterior. As the ankle is plantarflexed, one is stretched and the other is relaxed, and as it's dorsiflexed, the opposite happens. So this is the so-called sort of seesawing of the sciatic nerve in the popliteal fossa. So essentially that can be that you can block the nerves at or the position you get the patient in. You can have this patient prone with their foot on a rolled up towel to slightly kind of flex the knee. You can have the patient lateral with the operative or the side to be blocked uppermost. You can have the patient supine with either their foot held at, or their knee and their hip bent at 90 degrees and held, or with the patient's foot on the trolley and with the probe right behind the knee. Or in fact you could have the patient's ankle on your shoulder, and then that will allow you to hold the probe in either your right hand or your left hand and come in medial or lateral to then block those two nerves. Now, just to complete the block below the knee, this was the saphenous nerve. So this is another diagram from Neuraxiom. So a really useful website to look at. And again, the blue rectangle represents the probe position. So what we're looking for is the femoral artery in the thigh, and the nerve will run slightly medial and slightly anterior to the femoral artery. So you've got obviously Sartorius has been removed in this diagram. So if Sartorius were still present, you would need to go sort of posterior to Sartorius, but anterior to adductor longus. So when I was first shown how to do this block, I was told that if you just find the artery and do a periarterial wheel of local anaesthetic, you will almost certainly get the artery. And we can probably do slightly better than that, in that if you find the artery and find the tissue kind of plane between sartorius, adductor longus, and vastus medialis, then you'll be in a pretty good position to kind of find the nerve. So we've just got a video clip of that. So there's the artery there. Anterior is the blue dot. So sartorius there, vastus medialis there. Now, if we're just sliding up and down the thigh. So I'll pause the video there. Now there's the top of the artery there. This is the kind of the tissue plane that we are looking at. And if we wait a little bit further on the video, we should get a nice view of the saphenous nerve. So if we look at this structure here, and that structure there, that, if we just keep an eye on that, just as we kind of angle up and down, that's the saphenous nerve mid-thigh. So to block that would then complete the ankle block with the popliteal sciatic. So you can get a complete block below the knee with those two blocks.